starting out in chapter 1 of this book is basically essentials of physical agents. And I call this lecture the physiology of physical agents. And we'll talk about different things. We're going to start here, and then we're going to talk about throughout the quarter all the different physical agents and address some of them in lab. And we're not going to talk about all of them. We'll talk about the most commonly used ones. And then we are going to circle back around to this chapter and kind of bring it all together at the end of the quarter. So it'll be awesome. You'll love it. The learning objectives for this chapter is I want you to describe the 3 categories of physical agents and be able to give clinical examples of each. Easy, right? Which physical agents would be indicated or contraindicated for a given treatment goal? And we'll talk about broad treatment goals and which physical agents, and there are lovely charts in the book. I love a good chart. 4 general contraindications and precautions for any physical agent and the reasons that each would be contraindicated. And then we're going to talk a little bit about documentation. There is a separate lecture about documentation and how we're going to do it for physical agents, and it'll be so fun. We'll get to practice a lot. So physical agents, by definition, they are energy and materials that are applied to a patient to achieve a therapeutic effect. And it includes heat, cold, water, pressure, whether it's mechanical or manual pressure, sound, electrical currents, and electromagnetic radiation. So lots of different things. And a physical agent usually describes a type of energy. So it's mechanical energy, it's electrical energy, it is chemical energy, some type of energy. The phrase physical agent is used interchangeably with physical modality, biophysical agent, or just modality. And a lot of times, verbal shorthand, we usually just say modalities. So we're going to use some kind of modality to treat someone, to treat a given treatment goal. So the categories, the 3 broad general categories of physical agents include thermal, mechanical, and electromagnetic agents. So thermal agents transfer energy to a patient or from a patient to increase or decrease tissue temperature. So hot packs transfer energy from the hot pack to the patient. Ice pack transfer energy from the patient to the ice pack. Ultrasound converts electrical energy into sound energy, which has effects on the tissues, which we'll talk about in detail. Diathermy converts electrical energy to heat. Water and hydrotherapy can be thermal to transfer heat to the patient, or they can also be mechanical. We'll talk about that. Temperature changes from thermal agents may be superficial or deep. So hot and cold packs and water hydrotherapy tend to be superficial, and ultrasound and diathermy tend to be deep. So mechanical agents apply force to increase or decrease pressure on the body. So water or hydrotherapy can also be a mechanical agent. Traction, compression, ultrasound can be a mechanical, it can be a thermal, a mechanical agent. And you could sort of think of it as an electromagnetic agent too. So ultrasound is a lot of stuff going on there. Soft tissue mobilization and myofascial release, any kind of manual therapy, is also a mechanical agent. And even though that's not discussed in the book, we're going to talk about it a lot in lab and in lecture. So soft tissue mobilization is part of the category of mechanical agents. Electromagnetic agents, they apply energy in the form of electromagnetic radiation or electrical current. So that includes UV radiation, which is not used in PT as much anymore, even though it's still used in dermatology. But infrared radiation, also not used very much anymore. Laser, definitely used more. Diathermy and electrical currents. So physical agents can do a lot of things. They can reduce inflammation. They can accelerate tissue healing. They can relieve pain. They can alter collagen extensibility, and they can modify muscle tone. So, physical agents, even though they are not used as much in PT as they have been in the past, they are still useful for a lot of things. So, one of the things that is probably not used as much as it used to be is electrical stim, but in neuro rehab, electrical stim can be one of the primary things that you do for modifying muscle tone. So even though physical agents are not used as much as they used to be in therapy, they are still used, and they are part of our body of knowledge that we need to know. So one of the reasons that we're going to use physical agents is to promote tissue healing. So this is the table from the book, and I love these three tables from the book. Physical agents for promoting tissue healing is table 1.2. Physical agents for the treatment of pain 1.3, and physical agents for the treatment of tone abnormalities is 1.4, and treatment of motion restriction is 1.5. So lots of good info in those tables. Nice summary of info. So the tables, they talk about the stage of tissue healing, so initial injury, chronic inflammation, and remodeling, and we will review all those stages in the next section. And the goals of treatment, what agents can be effective and which ones don't you want to use that can be contraindicated. So just as an example, in the initial injury, if your goal is to prevent further injury or bleeding, static compression or cryotherapy can be used. And contraindicated exercise, when you have initial injury, you probably want to rest that injury initially, and then exercise gets right back in later. But intermittent traction, you don't want to use that with a new injury. A motor level electrical stim, you don't want to use that. And thermotherapy, you don't want to use it because you don't want it to bleed more. So so if you look through that chart, you'll see lots of different treatment goals or indications on what agents might be effective and then which ones you don't want to use. So pretty interesting. For pain, acute pain, referred pain, radicular pain, or pain caused by malignancy, a lot of them can be addressed with physical agents. A lot of goals for motion restrictions can be addressed with physical agents. And then a lot of goals for tone abnormalities can be addressed with physical agents as well. So those tables in chapter 1 are kind of good for like, wow, what are all the different things I could use for that? So on the very last exam, there's a case study where you could use anything and you come up with it. These tables would be a good way to study for that. Just saying. We're already thinking about the last exam, and it's the first week of class. So in general, the contraindications for any physical agent are pregnancy, malignancy, any kind of pacemaker or implanted electrical device, or impaired sensation or mentation. So if somebody is pregnant, they are growing a new human being in their body. You do not want to use modalities. So if anybody in class were pregnant, we would not practice on them because that would be a contraindication for any of our physical agents. So, and we'll keep talking about that. And malignancy. So cancer, as we talked about last quarter in pathophysiology, we've got fast growing cells. So we don't want to do anything that affects those fast growing cells or anything that might mechanically break it up and allow it to spread throughout the body. So malignancy is often a contraindication for everything. If you have a pacemaker and you're using any kind of mechanical, electrical, whatever device, that could be a problem. You don't want to mess with someone's pacemaker or their spinal stimulator or their insulin pump or anything like that. If they have impaired sensation or mentation, they're not going to be able to report to you what they're feeling or what's going on, and modalities are probably not the best choice for that person. So when you are choosing a physical modality, um, addressing you want to address either their primary problem or the problem most likely to respond to available interventions first. So the highest priority things are things that are most likely to respond to treatment or that are the underlying problem that are, causing the issues. Um, Using treatments that address more than one problem simultaneously are useful. Like ice addresses edema, inflammation, and bleeding. So it addresses three things. That's kind of nice. Um, when you're doing symptomatic treatment only, yes, that can be useful, but that's probably your lowest priority. You want to address the underlying problems as much as possible, but not to say that symptomatic treatment is bad, because it's not. It can be very helpful to someone just getting through their day-to-day life. So we want to, when we're considering selecting physical agents, we want to take into consideration the goals and the effects of treatment, any contraindications or precautions, evidence for physical agent use. So our evidence-based research project this quarter is going to be to look at some research articles about different modalities and kind of classify them a little bit. And we'll talk about in a little bit about how we're going to do that, and decide, is there good evidence for the use of this physical agent? And sometimes there is, and sometimes there isn't. And then cost, convenience, and availability. We want to use something that a person can benefit from. One of the things, laser light therapy has a lot of good research that supports it for a lot of different applications, but it's not usually reimbursed by insurance. So a lot of especially private practice therapy doesn't think it's worth the cost. And usually you get the most benefits from being treated every day, and that's not really available to most people to be able to come into PT every day. And so for that reason, even though laser light therapy has evidence for it being useful for a lot of different goals, it's not used as often because of the cost and availability and convenience, the patient not having to come in every single day. So different things to consider. A lot of times, interventions are combined when they have similar effects, like ice and compression to reduce inflammation and edema, or when they address different aspects of a common array of symptoms. So elevation and compression are combined to treat inflammation. Physical agents are more commonly used during the initial rehabilitation sessions. And then we sort of wean people off of them after that. So a good example is I was working with a lady in the clinic who had ankle surgery, and she had quite a bit of chronic inflammation, pain, and motion restriction. And it was probably 6 months to a year after her surgery. I don't remember the specifics of that. So she came into PT, and the physical therapist evaluated her and came up with a plan. We were going to start off with some modalities and some manual therapy and work into exercise and balance and gait and everything to improve her overall function. So during her initial sessions, we tried starting her out with warming up with exercise, like warming up on um, an exercise bike or some type of machine, and she couldn't tolerate that. It was too painful for her. So we started out in the initial sessions with ultrasound as a warm-up, um, manual therapy in the form of soft tissue mobilization, and manually resisted exercises, and passive and active assisted range of motion. And as she was getting better, we were able to progress her to an active warm-up instead of the passive warm-up. And then we were eventually able to get her into exercise. And so we started off with the modalities when she couldn't tolerate as much, and then we worked her into a more active treatment plan. So it worked great for her, and that's just one example of many, many cases to that effect. So we're going to document our modalities. And the reason we're going to document everything we do, we want our documentation to be effective, accurate, and complete communication to other healthcare professionals regarding our exam findings, our any evaluations or assessments, interventions, and plans. The documentation serves as a long-term medical record. It supports reimbursement. In other words, insurance company is reading your documentation to make sure that they want to reimburse you. And the patient can also read their documentation in modern electronic documentation systems. And a lot of times patients will come in and they'll say, well, I read my note and I feel like we need to address this and this. So patients are reading the notes, and it's another way to communicate with your patient. So documentation is super important, and it's something we're going to be working on a lot this quarter.